Now Professor Popescu will show us how to assess diastolic function. First, he will explain that it's very important to take into account the left ventricular geometry, left ventricular volumes, left ventricular systolic function, and also left atrial volumes. Then he will move through all the different diastolic function parameters and show us how to assess them in the clinical practice. And finally, he will look at the filling pressures and how to evaluate them with echocardiography.
I will talk to you today about the assessment of left ventricular diastolic function, a topic which is of great interest in clinical practice. The key point is that as we do not have a single parameter reliable enough to tell us everything about LV diastolic function, we need to do a comprehensive examination whereby combining information provided by different techniques, we can get a thorough assessment of the level of LV diastolic function and of the filling pressures. So the examination will start by looking at the structure of the heart and by assessing important parameters such as the mass of the left ventricle and the size of the left atrium, because these structural changes support very much the diagnosis of left ventricular diastolic dysfunction when they are increased. They also represent criterion to be used to make the diagnosis of heart failure with preserved ejection fraction an increasingly recognized and prevalent entity. So it is very important that we have a good ECG tracing, because many of the things that we'll measure will need to be concorded with the ECG tracing, and this is very important for the timing of events and for all the measurements. We will start by doing a parasternal view and looking at the thickness of the LV walls and of the cavity, because this will allow us to calculate left ventricular mass based on the thickness of the walls of the left ventricle and on the diameter of its cavity, and the level of the size of the left ventricular mass will then be indexed to the body surface area of the patient, and based on the value that we get, we know that the patient has a normal LV mass or whether there is present left ventricular hypertrophy. As I said, when present, this is an argument favoring and supporting the diagnosis of diastolic dysfunction together with the other signs which we will talk about later. The size of the left atrium is a very important parameter. We can already look at this from the parasternal long axis view, but this only shows us the anteroposterior diameter, which we know that it is underestimating the true size of the left atrium. So the recommended parameter is measuring left atrial volume from the apical views, because the measurement of left atrial volume reflects in the best way the size of the left atrium. The background of using the measurement of left atrial size as a parameter of left ventricular diastolic function is the fact that the left atrium is in contact, in direct continuity with the left ventricle during the diastolic phase. So whenever there is increased pressure in diastole in the ventricle, this will reflect backwards into the left atrium, and the left atrium will react by increasing its size. What is important about the volume of the left atrium is that it not only reflects the severity of diastolic dysfunction, but it also reflects the chronicity of the disease, because the size of the left atrium doesn't change overnight, and as it has been said, the volume of the left atrium is in a way the glycated hemoglobin of diastolic dysfunction, because it reflects not only the instantaneous increase in LV pressure, but it reflects the chronicity of the disease. How we practically do it? We start from an apical 4-chamber view, well acquired, trying to avoid foreshortening. We freeze the image and we select the frame which is immediately before the opening of the mitral valve. That means the frame where the size of the left atrium is maximal, and then we measure the volume of the left atrium by tracing the walls, and the recommended parameter is left atrial volume measured by the area length method. You see we got a volume of 48 milliliters in absolute value, which for a patient who has 2 square meters body surface area means an indexed LA volume of about 24 milliliters per square meter, which is exactly within the normal limits in a normal subject. Of course, we can also measure the volume of the left atrium in the 2 chambers as well, and then we may calculate the biplane volume of the left atrium in order to be more accurate. We can also use the 3-dimensional volume of the left atrium, which was shown to be a more accurate measure of the size of the left atrium. After having assessed the structural part of the heart, looking at LV mass and looking at the size of the left atrium, we move on, and the first step by using Doppler echocardiography is the recording of the mitral inflow. This is also historically the first parameter that was used for the assessment of LV diastolic function. It has the advantages that it is widely available and it is reproducible. How do we practically do it? First of all, we need to use the 4-chamber view, and we put on the color Doppler in order to see the way the flow propagates into the ventricle. Then we place a cursor inside the flow as parallel as possible, because we will use Doppler and we need to observe the Doppler principle. And then we place a sample volume, which can be 2 to 3 millimeters in size, between the tips of the mitral leaflets, and we record the spectrum that we obtain. We can get something like that, and we have, in a patient in sinus rhythm, we have 2 waves. The first one is called the E wave, and it is the early filling wave, which therefore relates with the level of left ventricular relaxation, while the second one is called the A wave, from the atrial contraction, because this is given by the contraction, by the booster pump function of the left atrium. You can nicely see in this tracing the relationship between the electrical activation of the atrium, which is given on the ECG by the P wave, and then after the electrical activation you see the mechanical contraction, which is recorded as the A wave. The A wave is a late diastolic event, so it will be related with compliance and with filling pressures. It is best related to the level of left ventricular and diastolic pressure. And these waves change based on the level of the filling, on the level of LV relaxation, but unfortunately also based on different other parameters apart from diastolic function. So sometimes the interpretation of mitral inflow in isolation can be challenging, because we can have a normal pattern or a pseudo-normal pattern. In other words, both look identical, but one is normal and the other is abnormal. In order to differentiate between these two, we need to use additional methods. So the assessment, the Doppler assessment of diastolic function, starts with the recording of mitral inflow, and based on the pattern that we get, we have the well-known classes of diastolic dysfunction. the first degree of diastolic dysfunction is called impaired relaxation. And in a patient who has impaired relaxation, the velocity of the E wave becomes smaller because it is more difficult for the atrium to empty into a rigid ventricle, and consequently the level and the peak velocity of the A wave is increasing to compensate for that. Later on, the second stage of diastolic dysfunction, when there are also increased filling pressures on top of impaired relaxation, this will lead to the so-called pseudonormal pattern, whereby again the E wave will be brought back to normal, and this is why it is called pseudonormal. And in the very late stages, the third degree of diastolic dysfunction is the so-called restrictive filling pattern, whereby we will record a very tall E wave with a small diminutive A wave, and so an increase in the E over A ratio. What we measure at the level of this profile, and I will show you, is actually a few parameters. So the primary measurements, in accordance to the recommendations for the assessment of diastolic dysfunction by the EAE and the ASC, are the peak E wave velocity, the E wave deceleration time, and the A wave velocity. So we will have, and then the machine may tell us immediately the ratio between the E and the A wave. We will have the deceleration time, and we have both the E and the A peak wave velocities. There are some other parameters at the level of the mitral inflow that can be utilized for the assessment of diastolic function, most notably the duration of the mitral A wave. The background behind this is that whenever the pressure in the ventricle becomes increased, the LV end diastolic pressure is increased, there will be an abbreviated A wave. In other words, the duration of the A wave will be reduced. But this parameter is best utilized by comparing it, and I will show you next, with the duration of the atrial reversal wave at the level of the pulmonary vein flow. Another parameter that can be used close to the mitral inflow is the recording of the isovolumic relaxation time. And one can do this by placing the cursor, the Doppler cursor, between the aortic flow and the mitral inflow in order to record simultaneously both the closing of the aortic valve and the opening of the mitral valve, therefore delineating the isovolumic relaxation time. As the name implies, this is a parameter which is a good marker of the relaxation of the left ventricle. The slower and the impaired the relaxation, the longer the isovolumic relaxation time. In other words, it will take longer before the ventricle relaxes and the mitral valve opens. However, in later stages, when left atrial pressure increases, this will lead to a pseudonormalization, shortening the isovolumic relaxation time back again. And so this is a disadvantage because, again, also here, we sometimes cannot say whether a certain measurement is normal or pseudonormal. But in concert, using it together with other parameters, as I said from the beginning, it can help us to get the conclusion. So, briefly summarizing the mitral inflow, we have the E wave, which is a good parameter of relaxation, and when relaxation is impaired, we have a reduction in the velocity of the E wave and the prolongation in the E wave deceleration time. And we have the A wave, which is mostly related to compliance and to the level of filling pressures, notably with the LV-EDP. And we can measure the ratio of the E over A, and based on the pattern of the mitral flow, we broadly categorize the diastolic dysfunction degree into impaired relaxation, pseudonormal, and restrictive. The next step, again using conventional pulse wave Doppler, is to try and acquire the pulmonary vein flow. The idea behind using this flow to assess diastolic function is that when one looks at the flow entering the left atrium, one could get information about the pressure that the blood meets in the left atrium. For this, practically, we will use again the apical 4-chamber view, but we will try to modify it in a way that we see very well the blood flowing from the pulmonary vein into the left atrium. For reasons of alignment, the best vein to use is the right upper pulmonary vein, which opens up next to the interatrial septum, and you can see it here. The trick is to always use, first of all, color Doppler in order to see it. Then, as I did, you can adjust a little bit your scanning plane by moving the transducer in a way that opens up the right upper pulmonary vein and really shows you nicely the flow, the blood flowing into the left atrium. Then you need to place a sample volume of pulsed wave inside the pulmonary vein, as I'm showing you here. And this has to be well within the pulmonary vein, at least 5 millimeters from the junction of the vein with the left atrium. And one would record normally 3 waves. 2 waves are forward flow normally, a systolic one named S, a diastolic one named D, and you can have a reversal, atrial reversal or AR wave, which corresponds to the contraction of the left atrium, and again you see the correspondence and the chronology with the P wave on the ECG. Now, what do these waves mean? The S wave means flowing of the blood from the pulmonary vein into the left atrium in systole, when the mitral valve is closed. So whenever the pressure in the left atrium is increased, then one would get a smaller S wave. In other words, the smaller the S wave we record at the pulmonary vein flow, the higher the pressure in the left atrium. And you can do it by measuring the S wave, by measuring the D wave, by expressing this as a ratio, or by measuring what is called a systolic filling fraction, whereby somebody may trace the S wave and record it and compare it with the tracing of the full forward flow, that is the combination of the S and D waves. Again, the smaller the systolic filling fraction, the higher the pressure in the ventricle. Importantly, this parameter works reliably only in patients where the ejection fraction is reduced, and it is not really a useful parameter to assess filling pressures in patients who have preserved ejection fraction. The same thing applies for the mitral inflow pattern. It works very well in patients with reduced ejection fraction. In other words, if you see someone with a restrictive pattern and a short DT, in the presence of a reduced ejection fraction, one can reliably say the pressures in the ventricle are increased. However, simply looking at the mitral inflow only in a patient who has preserved ejection fraction does not allow us to reliably estimate the level of filling pressures. So obviously another important thing that I didn't mention, when one looks to begin with at the structural aspect of the heart, of course we also need to assess the level of the ejection fraction, even if this is a systolic parameter and not a diastolic one, because based on that, some of the diastolic parameters will work better or not so well. Coming back to the pulmonary vein flow, the third wave that we discussed about is the AR wave, and it is this tiny wave that you can see here. Okay? Now, I told you that the duration of the mitral A wave is an important parameter, and it is very important to compare in the same patient the duration of the mitral A wave with the one of the pulmonary vein AR wave. The idea behind this is if we think what happens when the left atrium contracts. When it contracts, it can eject blood either forward into the ventricle or backward into the pulmonary vein. Therefore, whenever the pressure in the ventricle is increased, it will eject preferentially more back into the pulmonary vein where the pressure is low. So the duration of the AR wave will increase in comparison with the duration of the mitral A wave. Therefore, by simply measuring the duration of the atrial waves at the mitral flow, and you can measure it, and you can see in our patient here it was 159 milliseconds, and if you compare this with the duration of the AR wave, which is 143, you will see that in this case the duration of the mitral A wave is longer, which means that it is a good suggestion that the pressure in the left ventricle is normal. Importantly, this parameter, namely the difference between the durations of the AR wave and the mitral A wave, works also in patients who have preserved ejection fraction. And this is important to remember because we do not have so many parameters to assess filling pressures in patients who have preserved ejection fraction. We will now move to newer methods, actually not so new any longer, but newer compared to the most conventional ones that we talked until now. And I would like to spend a few minutes to show you how to do the tissue Doppler assessing, which is very popular because it is, again, widely available, it is reproducible, and it is feasible to perform. In other words, we can record it in basically every patient. What we will do for that, again, we start from the apical four-chamber view, and this time we focus on a single wall. We can start by looking at the interventricular septum, and we place the tissue Doppler color first, reducing the width of the screen to get a good resolution, and then we place a sample volume of pulsed wave Doppler within the basal segment of the septum so that it stays within the myocardium throughout the cardiac cycle, and we record the movement of the interventricular septum throughout the cardiac cycle. Obviously, we will have a systolic wave, which is positive because in systole the annulus moves towards the apex, which is relatively fixed. And then, again, in a patient in sinus rhythm, we will have two waves. The first wave in early diastole, which is called E prime, and is related to the level of myocardial relaxation, and the second wave in late diastole, which is called the A prime wave, and we call them prime in order to differentiate them from the respective mitral flow waves. Now, the important thing is by measuring the peak velocity of the myocardial motion in early diastole, in other words, the E prime, this will be a parameter well related with how fast the ventricle is relaxing. And in a normal young guy, we will have a high velocity of motion. In this case, it's 13 centimeters per second. And you see, since we have also recorded the E wave, the machine already displays the ratio between the E over E prime, which is an important parameter, and I will get back to that when we will discuss the combination of the parameters. So it is important to record it in a right way by placing the sample volume in the right position, by carefully adjusting the settings related to the gain and to the wall reject in order to get crisp waves recorded of the profile, and then one can really measure easily the peak velocities of both E prime and A prime. Of course, the problem is that here we use a regional parameter trying to derive global information. And this may be tricky in patients who have a heterogeneous contraction or function of the ventricle. Therefore, the recommendations state that we should use several measurements from several walls, from several parts of the mitral annulus, and to use the average value, because in this way we will incorporate information to be used globally. This is particularly valid in patients who have wall motion abnormalities, such as patients who survived myocardial infarction. So measuring tissue Doppler pattern at the level of the septum is one of the options. The other option is to try and measure myocardial velocities at the level of the lateral wall. For this, you have to adjust your transducer position in order to try to align as parallel as possible the motion of the lateral wall with the Doppler beam, and so to be within a small angle of insonation. And then you can record it, and again you will see in such a healthy subject you can have very nice tracings, and you will see a completely normal pattern. This time E prime is higher, and this is another important point, the fact that we need to take into account that not every measurement is interchangeable, because the lateral wall, which is free, moves faster than the septum, which is shared between the two ventricles. So the velocities we record across the lateral wall are higher in a normal subject than the ones at the septum. This is important because then the cutoff values that we will use in order to say whether there is diastolic dysfunction or the level of filling pressures will need to be adjusted based on the site that we have used to record that particular wave. In this case, you saw there was the 13 centimeters per second E prime at the level of the septum, and here we have a 15 centimeters per second E prime at the level of the lateral wall. Usually in a normal subject, in subjects who do not have wall motion abnormalities, it is enough to record the septum and the lateral wall. In other instances, it is useful to do it also in other two sides of the annulus, possibly the anterior and the inferior one, as we can record by using an apical two-chamber view. So one could do that, moving to the two-chamber view in a right way. And again, the trick is to adjust your view in order to bring the wall of interest in the center of the screen as close as possible in order to get a parallel alignment between the motion of the wall and the cursor of Doppler. Now, I told you that E wave at the level of the mitral flow relates with relaxation, in the sense that impaired relaxation leads to a reduction in the velocity of the E wave. On the other hand, I also told you that whenever the pressure in the left atrium increases, this will lead to an increase in the E wave velocity. So the E wave velocity at the level of the mitral inflow is basically governed by several parameters, but the opposing effects exerted by impaired relaxation and increased filling pressures may make the interpretation of the mitral inflow difficult. However, if we take the E prime wave from tissue Doppler, which was shown to be related with the constant of isovolumic relaxation tau and not so much influenced by loading, then we may have a ratio combining the two, and this is called the E over E prime ratio, which I've already showed you. And this ratio, by canceling out the effect of relaxation will be directly related to the filling pressures. And this was the big advancement brought by tissue Doppler, and among its applications, maybe this is the most important one, because there is this parameter combining two measurements from two different views, but which are easy to acquire, and the result may orient the clinician as to the level of filling pressure, which is a very important pathophysiological parameter because it relates not only to symptoms, but it also relates to outcome, to prognosis. However, there is still a problem with this parameter because whenever the value of this ratio is below 8, the pressures are likely to be normal. When the ratio is above 15, the filling pressures are most likely elevated. But in a broad range between 8 and 15, there is a gray area where we cannot really say something reliably about the level of filling pressures. And it is in that particular area that we need additional information to add on top of that if we are to figure out the level of filling pressures. The filling pressures are a very important parameter in the assessment of diastolic function because they represent the final common pathway across the progression of diastolic dysfunction, irrespective of the initial etiology. If the cardiac disease is severe enough and long enough, it will lead to an increase in filling pressure, which will give rise to symptoms and will alter prognosis. So it is important to have parameters to use to assess filling pressure. Now, the assessment of filling pressures may be done through different parameters. Some can be used when the ejection fraction is reduced, like the E/A ratio, or simply the E-wave deceleration time. But on the other hand, when the patient has preserved ejection fraction, we do not have so many options, and E/E' comes as the first choice to use in order to assess filling pressures in a patient with preserved ejection fraction. Finally, there is one more modality which is recommended in order to assess diastolic function, and this is color M-mode measurement of the flow propagation. What is the background in using this to assess diastolic function? The idea is that instead of looking at a single location by placing a sample volume between the mitral leaflet tips and trying to derive from that single information global information about diastolic function, we can try to assess the propagation of blood all the way from the annulus of the mitral valve towards the apex, because the way it propagates, the speed of this, the velocity of this flow wave, again will relate with the relaxation of the ventricle. A very actively relaxing ventricle in a young patient, in an athlete, the flow will propagate very fast in a few milliseconds from the annulus towards the apex. Conversely, in a patient with a very sick ventricle, dilated with poor function, it will take a long time for the wave to reach the apex because it will not travel directly, it will rather go in circles towards the left ventricular apex. So, velocity propagation was shown to relate with the time constant tau of isovolumic relaxation, and this is the background of using it. How do we practically do it? Again, we start from the 4-chamber view. This time we can focus more on the ventricle. We do not need a lot of the left atrium because we are interested in looking how the flow propagates again from the mitral annulus towards the apex. So first of all, we place color Doppler trying to encompass the full left ventricle. This will also show us the direction of flow propagation. So we can align a Doppler cursor parallel with the direction of propagation, and on top of that we will press the M mode button. And we will get something like that, which shows us basically the way the blood flow propagates in early diastole from the mitral annulus, which is here, you can see it closed in systole and opening in early diastole, towards the apex, which is here at the top of the screen. Now, you can simply measure the slope of this flow propagation, and this is actually Vp. How can you do that? You can select from the measure button the slope caliper, and you can really assess this, and you see the normal value in a normal subject should be above 50, and the higher, the better the relaxation. In this young subject normal function, it is 65. And the trick is to try and get a linear interface between the color and the no color. And if this is not really possible, we can play with the baseline by adjusting the baseline in order to change the aliasing velocity and to get a linear flow, a linear slope that sometimes is easier to measure. Limitations relate to the fact that sometimes in small ventricles the flow propagation can be normal despite the fact that relaxation is abnormal. And of course there is a wider variability, so the reproducibility is not as good as for tissue Doppler or for the mitral inflow. Again, this parameter, the Vp, in this case it was 65, can be used in combination with the mitral E wave in the same respect, in the sense that if someone combines a parameter related to both filling pressures and relaxation with one which is mainly related to relaxation, the effect of relaxation cancels out, and we have a ratio called E over Vp, which should be related directly with filling pressures. Normally this ratio should be below 1 in a healthy young subject, and whenever it is increased, it may mean an increase in filling pressures. The higher the E over Vp, the higher the pressure in the left atrium. Above 2 and above 2.5, there is a high likelihood that the pressures are increased. Finally, again, moving a little bit from the left side of the heart, we need to remember that whenever we have diastolic dysfunction, significant diastolic dysfunction, this will give consequences on the right heart as well. And most of these patients with significant diastolic dysfunction will have an increase in the level of the pulmonary artery pressure. So it is important to record, whenever possible, trace the tricuspid regurgitant jet. Sometimes when patients are normal, this is not easy to get, but anyway, there is mild TR in most of the patients who matter, in those who have diastolic dysfunction. So you can see we can find it in several views. Sometimes we find it in the right ventricular inflow tract, sometimes in a modified 4-chamber view. Then we align the cursor with the direction of the TR jet, and then you can have the spectrum of tricuspid regurgitation. Here is a faint signal because there was really very mild TR. And then if you measure it in this normal subject, it is a gradient of 17, which together with the pressure in the right atrium will give us a totally normal pulmonary artery systolic pressure of around 20. So I would say that we need to combine all the information. We start by looking at the heart structure. We assess left ventricular ejection fraction to know how to use our parameters. Importantly, we assess left ventricular mass by measuring the wall thickness and the cavity diameter of the left ventricle. Very importantly, we assess the size of the left atrium by measuring left atrial volume and indexing the measurement to body surface area. And then we move to the parameters acquired by Doppler. And we have mitral inflow, we have pulmonary vein flow. We can combine those by looking at the differences in duration of the A wave. We then have tissue Doppler, which is very important, and the importance of measuring VP by color M mode became progressively lower because most of the information we get from it can actually be gathered from the others. However, in a difficult patient where we really are borderline and are not sure what the level of diastolic dysfunction degree and severity of increase in filling pressure is, we can use VP as an additional parameter which may sometimes be very helpful. Finally, also importantly, we try to assess the level of pulmonary artery pressure because we know that in patients with significant diastolic dysfunction, most of them will have some degree of increases in the level of pulmonary artery systolic pressure.
So to conclude, you see that it's very important to have an integrative and comprehensive approach of diastolic function. And moreover, we have to take into account the clinical context and also the loading conditions.